Well, good afternoon, everyone. Welcome. So glad that each one of you are here. Welcome to the talk on collaborative whole person care. I'm Michael Robinson, and this is Dr. Jamie Crowns. Unfortunately, our fearless leader, LaDonna, was not able to come today. She's our lead pharmacist at SAC, and we do have her slides, though, so we will present her slides. So you will get to hear her content, but unfortunately, she had to take a medical leave and was not able to come with us. So we wish her God's blessing in that. Today, we want to talk a little bit about collaboration with a pharmacist, but we'll also bring in the idea of how do we collaborate with all areas of healthcare. And both of us work at the SAC Healthcare. This is located in Southern California in the city of San Bernardino. My background is I just was hired at SAC. I came from a mission service, and so I'm a returning missionary. And SAC welcomed me with open arms. I was thankful for that, and they asked me to focus on missions there. So that's what I do. I'm a missionary there in Southern California. So if you want to be a missionary and go to Southern California, we're looking for people who can come help us to share the good news of salvation there. SAC is a community-based, federally qualified healthcare system. Today, we want to talk about the differences between solo practice and a collaborative practice in healthcare. We want to identify the positive aspects of a collaborative whole-person care and between a physician and a pharmacist and other areas of healthcare. We'll also talk about some illustrations of that today. Well, as I mentioned, we're at SAC. SAC is very unique in that it collaborates with Loma University, and it was started by a group of students back in the early 70s who were doing some street ministry for the homeless. I remember when I went through school there, I was back in the 90s. We went out, and by that time it had moved from street to the basement of a Salvation Army church. We were seeing patients there together. And then I graduated and went off to the mission field and have come back, and now it's a building and has medical students and residents and pharmacists and social workers, and has grown into multiple clinics. So that transition it's gone through for many, many years. It's as you can see, it's a teaching health center and now has become a federally qualified healthcare center. It provides whole person care, which is really what Loma Linda has brought to us. You know, as students there, they really focused on the mental, spiritual, emotional, physical aspect and how we need to address all of that. And as Christians and believers in Christ, we want to serve patients in all areas. You can see the numbers there we had for 2023, and we're committed to reflect the healing ministry and love of Jesus Christ through healthcare, education, and partnership. You know, I think of us as individuals and as a church group. You know, God, Father, Son, and Holy Spirit made the earth, right? And then he made Adam and Eve, and he put them into a family. And as we come into a church, we're into a collaborative church environment, aren't we? And that's really where God designs us to work. Sometimes we have to be by ourselves in a solo practice. I remember when I first started working, I had the mentality that I had to do everything. I had to make sure I reconciled the medication. I had to make sure I did all the social work for my patients. I had to do all the teaching for them. And it was a lot of work keeping up. You know, as a resident, I was thinking, I need to do all this. But as I grew more and more, I figured, you know, I can help. I can use the resources and help of my PA, the pharmacist, and the different people in the healthcare system. And so that has really been a blessing for me. I have a friend who started a private practice, and I watched him go through that development. He was a solo dermatology practice. And the nice thing about being solo is it's small, you have a small size, and you have a lot of autonomy. And I saw him be able to make decisions that in a large collaborative group you couldn't do. He could grow it as quickly or as slowly as he wanted to. He had close interaction with patients, and he could develop his own unique style. However, the disadvantages was he had to take care of everything: human resources, he had to hire and fire people, he had to recruit physicians as he grew, and then he did physician extenders. And I saw the difference between that and a multi-specialty office. Here at SAC, this is what our multi-specialty practice looks like. The patient is really the center, and we have multiple supporting systems around that. So we have behavioral health, we have the nursing, we have the primary care, we have the pharmacist, all those helping to make that patient's experience in the healthcare one that's very, very positive. WHO describes a collaborative healthcare model as a healthcare practice where multiple healthcare workers from different professional backgrounds work together with patients and families and caregivers and the community to deliver the highest quality of healthcare for that patient. And here at SAC, Dr. Kraus is going to talk a little bit more about the details of SAC, so I'm going to turn the time over to him.
All right. Nice to be with you all. My name is Jamie Crowns. My background's in family and preventive medicine. I work at SAC in a capacity in the quality department currently, but I spend a lot of time in the family medicine clinic, and I've worked with Dr. Oelschlaeger quite a bit. So as she put this together and needed somebody to share it for her, I'm more than happy to share it, because actually a lot of these things we worked on together. But maybe just to introduce the SAC team to you, we are a very unique FQHC. And I think the biggest uniqueness is the number of learners we have. So when we think about collaborative care, we may not always think about students or residents, but they're part of the collaboration. We actually routinely learn from them. I know I do. And so they're part of the team. And then because of the way we're made up with that academia, we have a lot of attending physicians as well. So a lot of, like another clinic I heard today was presenting, they had 500 volunteers and a staff of 50. So we're not quite that lopsided, but I kind of think of these attendings as like the volunteers. They come and spend half a day or 1 day a week and supervise residents. And then the nursing staff, of course, that's part of every clinic. We have a lot of specialty clinics as well, and that's part of what we've come to see as part of our mission, is getting our patients into specialties without having to wait a long time. And of course, we have primary care clinics, which are still the backbone of our clinic and do about 60% of all our visits. We have APPs as part of the primary care, and then behavioral health. We're blessed with a good-sized behavioral health department. We have a standalone behavioral health department, but we also have integrated behavioral health too that sits in the pods with us and sees patients in real time. We have dentists and clinical pharmacy services, which is what we're going to spend most of the rest of this time speaking about. I'm going to come back to enhanced care management because it's a very unique program that really illustrates the collaboration at SAC. And we do have a population health department as well that works on managing the health of our population in a centralized manner across the spread of the system. Okay, just out of curiosity, who's here? Do we have any pharmacists here? Okay, good. Docs or physicians, nurses, clinical staff? All right, okay. Well, anyway, it's just good to know who we're talking to. So I think we would like to share, again, like this is the disclaimer for every talk, right? We've done stuff. I'm guessing some of you have done better things than we've done in this area. Well, I'm sure you have. But just we're going to share kind of what our experience has been. But maybe just a little bit of literature first. Obviously, the clinical pharmacy physician collaborative is an enhancement of the team. We're building up the competency of that clinical team. What we're going to describe to you actually happens in the clinic at the point of care. And the literature said, there are some kind of hard and fast things that actually do happen when this collaboration happens. There's a decreased interval to getting a diabetic patient at their glycemic control. And I've seen that over and over again. To the point where in our clinic, if we have a patient whose diabetes is uncontrolled, I almost don't even want to try thinking about it. I just kind of want to say, you just need to talk to our pharmacist. I mean, obviously there's work for us all to do, but you just need, especially if it's been that way over time. And we've talked, and let me introduce you to LaDonna. LaDonna will help you because it really has been such a valuable service for us. And it helps patients. It really moves them towards their goals faster. And that is evidence-based. And then, in that capacity and many others, I mean, that's just one example, clinical pharmacists can initiate, monitor, and modify the drugs that are being used in the clinical services. Now, I am guessing this is different in the location and the practice you're in. I know different practices have different levels of autonomy for this. I would say at SAC we're pretty autonomous, but what we don't have at SAC is a financial mechanism for a pharmacist to bill for a visit. And so I don't know that that's the same everywhere. That is our setup as our FQHC at SAC. So it's a limitation of sorts. We figured ways around it. But as far as the kind of functioning independently, we work together, but our pharmacist has our confidence, and so she functions pretty independently, and we are very appreciative for what she brings. And so then, of course, this has been shown to make patients better. So what exactly is it that we do? I'm going to explain to you something called a medication management visit. So this is something that LaDonna and I worked on probably 2 years ago. And we worked on several iterations of this, and I would be remiss if I didn't say it had been a little bit of a struggle. And it probably still is a little bit of a struggle. We have success here, but we still, work on the different pieces of what goes into this. So I will tell you, we function, our EMR is an Epic, and probably much like any EMR, it has visit types. There is a visit type called medication management. So that is how we've set up this service. So what happens is when we're in primary care seeing a patient, their A1C is 15 and it's been 15, maybe it just got there, maybe it's been there for a long time. And we think, this patient would benefit from a pharmacist. We have a referral that we can place. That referral goes to a queue, and then the patient gets scheduled into a medication management visit. The medication management visits in our FQHC are scheduled underneath the provider's template. So this is a provider visit, but it's a provider visit where the provider does very little and the pharmacist does a lot, like an hour's worth of a lot often. So basically what kind of walking through the bottom here and what we do in this clinic, most of our referrals are for diabetes, maybe for hypertension, maybe for asthma. We don't do much warfarin anymore. I don't know if anybody else is, but in the past we've done that, but not much anymore. The DOACs seem to have taken care of that. So then the patients are scheduled for this visit, again, on the provider schedule, MD or APPs. And this is not to take the place of a regular PCP visit. This is like truly a specialty visit. So this isn't like come back for your diabetes in a month and we'll schedule you for medication management to follow up. This is an additional visit, like why don't you come back in 2 weeks and we're going to talk about your medications with a pharmacist. And we're going to really get the good stuff. We're going to get all the information, so bring everything you got. And then the team for these visits, the provider will interact with the patient, but minimally. It's typically a 3 to 5 minute interaction where the provider confirms, the diagnoses, the interval updates, how the patient's doing, and then kind of hands it over to really the work, right? So then the pharmacist will come and spend more time with the patient doing really a full medication management visit, which again, we found very helpful. That pharmacist often has 1 to 2 students. There is a medical assistant just because they're working with the doc and the provider. Before the visit, we do send out text messaging. I don't know if, I think that's become fairly routine, just to let patients know that they have the visit, but also encouraging them to bring all of their medications, because this is the one, like bring the whole bag, because we're going to have somebody who can actually sit with you and go through them one by one and get the real story, because I think we all know that story is very challenging for doctors to get and get it right, just because of the complexity of the multiplicity of medications that patients often have. So we text message them, say bring your medications, and the patient can actually cancel via that text if they want to, or reschedule, or otherwise confirm that they're coming for the appointment. So then during the visit, they're roomed, kind of like a normal patient. The one difference is our MAs typically do a medication reconciliation. They don't do that in these visits. We let the pharmacist do it. And then the pharmacist really does the visit. It says here 15 to 20 minutes. That's a good, I would say, fairly simple patient. There is a referral bias for these patients. They tend to be the ones that are really complicated, been in the hospital multiple times. They're accumulating a stockpile of medications and don't really know which ones they're supposed to be taking. And that can take a while to sort through, but it's so valuable that we have this ability to do it. So pharmacist meets with the patient, discusses with the team, and then the provider. After closing that loop, then the provider kind of wraps things up from the provider level visit, and the pharmacist gives their recommendations. So the way we are scheduling it is really 1 per hour. So that is probably a little longer than needed to do these visits, but we just respect that these patients are complex, and so we give additional time. I will tell you how this goes. Maybe there's 4 patients scheduled, but then Dr. Robinson's in clinic, and he has a patient that's not on LaDonna's schedule, and he says, "Hey, LaDonna, I had a question about getting a prior auth for this medication, or how about this treatment for asthma, or could you talk to this patient about initiating insulin," or whatever the theme of the day might be. She functions, our pharmacist functions in an integrated capacity as well as for the scheduled visits. So a little bit more detail on what the pharmacist is actually doing. So step 1, reviewing the diagnoses and allergies, kind of the routine things. She does take a medication history, including over-the-counter medications and supplements. Again, something that we're terrible at doing. She's very detailed about getting that information. Looks at the other information available in the EMR that would impact treatment, such as labs and other medications, and then comes up with recommendations. So really, just doing a comprehensive visit. And after that, then, though, comes like the discussion, right? Like there are always other factors, and that's one of the areas where I really appreciate our ability to have collaborative care. I meant to say this at the beginning, but I rotated briefly at Sac Health when I was a medical student, but not for very long. Then I went to Malawi. We worked in Malawi for 3.5 years, but during that time, I came back to fill in for a friend of mine, so we swapped. My friend, who's now the CEO of Sac Health, Dr. Jason Lohr, he went to Malawi and worked for 6 weeks for me in the hospital. And I came back to Sac Clinic and I sat in his precepting chair. So I precepted residents for 6 weeks. This was in 2014. And what I remember from that, there were like 2 things I loved about Sac. Like I could come back and be a doctor here because of these 2 things. One was they had integrated behavioral health. So we had basically a psychology intern sitting in our pod, ready to see a patient that needed help for depression or anxiety or some other problem. And 2, that we had integrated pharmacy. Because when there was, these complexities that arise with medications, the complex patients, they were able to help. And so that discussion, that collaborative discussion, is really kind of a heritage of SAC. It's something that I appreciated even before SAC was an FQHC. And it involves the whole team, right? It involves residents, students, pharmacists, pharmacy students, med students, pharmacy students, residents, attendings. It really is a very educational experience. And to hear the thought process, you can see the illustration of what Dr. Robinson was talking about in collaboration. And then, after that discussion, kind of get the recommendation. Okay, then, obviously you kind of have to go back and include the patient with shared decision making and see what their final decision is. And then the documentation is the final piece. So our pharmacists do write notes. They write a complete note in Epic. We are not able to bill off that note because of our limitations in our scope as our FQHC. But the physician can reference that note. And so the physician really needs to write a note that stands up to billing standards alone for what they have done. But it tends to be a lower level encounter. But then the pharmacist note has all of the details of what has been addressed in the visit. I will say, and you probably know this firsthand, especially for the pharmacist, that continuous glucose monitors are something else that we struggle with as providers. And we're so thankful when you help us with that. Insulin's gotten a little bit better with the pens, but we still sometimes need a little bit of help. So these are just areas. Oh, getting a blood pressure cuff. Does anybody else have a problem with like getting a blood pressure cuff? It seems to be one of the hardest feats in healthcare in Southern California. Okay, so a few benefits of this collaboration. So first of all, we get a comprehensive medication review, which I think as providers we love, as you know, the docs and nurses and clinical team, but struggle to have the patience to procure. So that's in and of itself is a wonderful resource. I think I already described the learner involvement and the dynamics between the learners in our clinic. Then maybe an additional, probably intuitive response is we also see improvement in our quality scores. And as a clinic, we have seen this. And exactly how much is due to these medication management visits, we have not tracked and are not currently set up to be able to track in our reporting. But we know that it's helping, right? This is helping us with our diabetes and hypertension quality metrics, as well as lipid management and asthma and a few others as well. And then, so, to just kind of summarize, this is another collaborative, another form of collaboration in our clinic. Okay, and then just some limitations, as I mentioned already. These visits are non-billable as the pharmacy standalone piece. So we are always attaching them to provider schedules. I think that has worked and that has not worked. And from our experience, that works when you have a provider who understands the value and the depth of understanding of the pharmacist. And so we have some providers like that. And it doesn't work when you don't have that. So if you have a provider who's kind of second guessing everything the pharmacist is doing, that turns into a very long conversation, very painful. And so I guess if I was going to give a little advice, it would be if you were ever to think of doing something like this, like find providers that have confidence, like there's a working relationship, they understand the role of the pharmacist, the value, the independence, and who really is willing to do a very quick checkup on whatever diagnosis is being addressed and then hand it off. Because if you don't do that, you're basically reinventing the wheel, and it's a little bit frustrating for everybody. Hopefully you don't have many situations like that, but we've had a couple in thinking this through. And we've learned from them and just realized there's certain providers, which are most, that this works for, and there's a few that probably don't have it work so smoothly. Okay, I'm going to switch gears. So that's kind of the end of what I'm going to say about our integrated pharmacy medication management visits. Hopefully I was able to sketch out kind of just what we've been doing there. On the line of collaborative care, and our pharmacist has been involved in this in the past, even though they're not actively involved in this program right now. I just wanted to share with you a unique program called Enhanced Care Management. This is, to my knowledge, unique to California, so probably not generalizable everywhere, but I think there's aspects of it that are definitely generalizable. So California came up with a new bill of funding 2 years ago. It's called CalAIM, and it paid for a lot of things. One of the things it paid for was a collaborative team. So for patients that have highly complex conditions, severe mental illness, homelessness, they're in and out of the ER or the hospital, they qualify for this program called ECM, and the clinic, our clinic, when we enroll a member, we get paid from the healthcare plan for this. And that payment covers this whole multidisciplinary team. So we have an MA, a CHW, some behavioral health, and some nurse case manager. So these patients get a lot of attention. And you can see right there is a very collaborative, multidisciplinary team. Unfortunately, pharmacy is not included in that nuclear team. And so pharmacy is a little more of an additional benefit when we can find them and reach them. And they do help us with this. But I did just want to share briefly that, this has been such a blessing to our clinic because these patients are challenging. They need extra help. And this program really does provide that for our patients. And so where are we currently with this program? We have 8 teams, 8 ECM teams with those 4 members on them, kind of spread across our system. And we're adding a couple more. This is a way that California is trying to shift the responsibility of all of these highly complex patients from the doctor to the team. And I appreciate that. What we get paid per member per month covers the whole cost of that team. And the team really can manage these complex patients better than the doc, as many of you know, right? Like the challenges of homelessness are not primarily something that the doc deals with better than anybody else. So anyway, we have 1,800 patients in this program. The team does admission and discharge management. They will go to the hospital. The CHWs will go to the hospital when a patient gets admitted and do a medication reconciliation. When the patient is discharged, they'll also make sure they understand the plan. They get a follow-up visit in the clinic. So a lot of additional patient care and management. They also do home visits and then just regular care planning. They and help scheduling. Like these teams really help patients get back in to see the providers when they need to. Okay, so I just wanted to share one example of a case study from this ECM team, just to put a little bit of flesh and bones on it. And then I think Dr. Robinson will share another case study from our clinic. So I'll just call this patient John. He was 65. He had untreated rheumatoid arthritis, and it was so bad he was sitting in a wheelchair. He couldn't walk. That progressed to where he couldn't drive. That progressed to where he had no money. He was unemployed. He was about to be homeless, and he was suicidal. So that's how he was when our ECM team kind of met him, and really largely springing from the failure to treat this chronic disease. And so what the team did when he was, what the team did for him was really hold his hand. Over the course of like 15 months, they called him about every day. They made over 100 appointments for him and got him into them. Lots of specialty appointments: rheumatology, dental, podiatry, ENT, audiology, ophthalmology, dermatology, and other procedures. They got him food on a program that we have in California called CalFresh. They got him transportation to the clinic. They helped him to get disability, as well as a back pay of about $10,000. And just on March 12, I think when they gave me this case study, the patient had just received his driver's license back. And today he's out of the wheelchair, he's up and walking around. He still has pain, but his pain is controlled to where he's able to function. He's not depressed any longer, and he's not anxious, and he wants to go back to work. And, I think just that picture, right? You have a debilitated patient that required so much intense care, but the team was able to give it. And what the whole team says now is, like, he's happy. Like, he started out suicidal because life was so bad. Now he's just always smiling. He loves the members of the team. He trusts them more than his family. And, I think we work at mission-driven organizations. I think we all have these stories. But just to see how those stories can come out of this collaboration is always very gratifying. All right, Dr. Robinson.
Thank you, Dr. Hounds. I'm definitely a newbie to SAC, and when I was onboarding, LaDonna came and talked to me, and she said, "This is what we can offer you." I thought, wow, that's fantastic. In the mission field, we don't have that. And so it didn't take long for me to need her help. I remember, I'm going to call him John. John came in. He was a 15-year-old young man who was brought in by his mom. And she said, John does not take any of his medication. He has diabetes. He was a young man for diabetes. and he had been put on a CGM before, but he stopped using his continuous glucose monitor because at school, the kids would come up and say, "Hey, John, how are you doing?" And, "Oh, what's that on your arm?" "Oh, you must be a robot." And they'd punch him. And he's like, "No, I can't wear that, Mom." Mom would say, "You got to do it." So when he'd go after sports, he'd go into the locker room and he'd change, and they'd see that on there, and they'd come up and, "Oh, there's the robot guy." They started bullying him because of his CGM. And so he stopped using that. And he said, "I don't want to have diabetes anymore." So he stopped taking his metformin, stopped taking his Lantus, and he just stopped taking his medications. And then he was in a family where, unfortunately, his dad was abusive, and he had been taken out of the family, and now he was put back from foster care back into his family again. So he had all these things going on. So I said, "LaDonna, help me. I need some help." So he sent him at his next visit to see her, and she got him on a regimen where he didn't have to take insulin, and started poking his finger. He was willing at 15 to poke his finger because he didn't want the kids punching him. Anyway, he came back and saw me, and he was doing much better. And this time we noticed there was more depression going on. And he was worried because his dad had now started beating up on his mom. And so he was worried he was going to be taken out of the home again. And so I sent him over to mental health and got Mom a referral to mental health as well. And the social worker had been in contact with Child Protective Services, so they were aware of his case. And so CPS came in as well and was monitoring the situation. So as you can see, we need multiple collaboration on multiple levels. And then on my badge, I didn't bring it with me today, but on my badge I have this little button that I wear on my badge. And on his third visit with me, he looked at my badge and he says, "What is that?" I said, "Oh, it says, 'How can I pray for you?'" And he said, "Where can I get one?" I said, "Well, would you like it?" He said, "Oh, sure." So I gave him my little button, and he said, "I'd like to wear that." I said, "Why do you want to wear that?" He said, "Because I'm going to go up into the mountains this weekend with my friends, and I'm going to be praying." I thought, wow. "Well, could I pray with you? Is there something you would like to pray about?" So I said, "Yeah." And so he told me his prayer request, and that gave me an opportunity then to refer him to the chaplain. So you can see how just this one young man engaged with multiple of our providers in the office. And I think that illustrates a good point, and that is look for opportunities, because each one of those contacts is a mission opportunity where we can help heal different parts of their lives. We're not one-dimensional, right? God made us multidimensional. And that spiritual component is so important. I really enjoy working with the chaplains there at SAC. If you don't have the opportunity, if you're in a solo practice like we talked about in the beginning, Don, my friend, who I talked about, he actually went out and talked to one of the local pastors in his community and said, "Hey, I want to work with you." And so he brought a pastor to his office, and they were there for a while. And eventually, as he got bigger, then he actually hired a chaplain into his office. Yeah, I'm thankful at SAC we already have a chaplain, but it's important to do that. I sent LaDonna an article. She didn't put it in her talk, but about how pharmacists praying with patients actually helps their healthcare get better, and that was a really good article. So prayer is really important. The spiritual component is so important to everything we do. So don't forget that as part of your collaboration. But now what we want to do is we want to hear from each one of you. What things are you doing right now that are encouraging collaboration in your setting? So help us all as we talk together, learn from your experience. What things are you doing that are unique maybe, or experiences that you've had as you collaborate with the team in your setting? Well, thank you very much. Appreciate all your input and feedback, and God bless you in your work in your field.